Okay, I think it might have I deleted the wrong recording for the slide because the dogs are barking. So this was the beginning, the bronchoscopy. Again, you're looking at chapter 18 in White, 17 in Wilkins, and 22 in Egan's. Alright, so just a little history of the endoscopy. Was first introduced in 1904 using a hollow, rigid tube, a bronchoscope. So the first types of tubes were very rigid, and then the, like super rigid, like just straight. And then the flexible fiber optics became, started in use in 1975. So think about, endoscopy is generally looking at your stomach, obviously colonoscopy the other end, and then bronchoscopy being for the lungs. But the scopes that they use are kind of similar. Alright, so the rigid scopes, and if you, there are several supplemental videos basically that are listed here under, let's see, what day are we on here again? Let's see, this will be day 6. So there's several resource videos, and most of them aren't super long, but you can see one where they use the rigid scope, a couple different ones where they use it to intubate, to do a laser procedure. So check them out, they're pretty interesting. I would definitely look at the last two where they have a bronchoscopy was used to get an aspirated whistle, and then looks like it's a thorn of some sort. Those are the very last two videos that are listed there. So if you get a moment, I would definitely check those out. They're pretty cool. Alright, so most of these scopes, and the rigid ones and the flexible ones that we use now, have different ports on them. You can deliver oxygen through them. You can also deliver general anesthesia. There's also a pathway for suctioning, and then another opening for to insert different tools to help you remove foreign bodies. And then also, kind of within the same tool there, you can also get biopsies there. So these different openings and different ports. 90% of the current bronchoscopies are performed using the flexible fiber optic scope. And this is an actual test question. The maximum depth that the standard adult bronchoscope can visualize is the 6th level of the bronchi. Okay, you will see that is from Egan's. Wilkins says like 4th to 5th, but on the exam it is 6th. Okay, and that will be on your exam 3. Alright, I gotta get the right mouse here. I got 2 computers open. Alright, so this is a picture of the bronchoscope here on the left side. It plugs into the Olympus, is generally the brand that we have at the hospital. It's like a kind of a monitor type of screen. It provides the light source when you click that kind of straight part in and lock it in place. And then the different ports are along kind of the black part there. You have the suction port, then you have the openings where you can insert the different tools that you might need, different wires, needle biopsies, a little alligator forceps, the basket. And then on your right side there, you kind of can visualize the carina. They're right in the middle, that kind of whiter part. And then your right main stem would be off to your right here looking at it, and then left would be to the left. So the right is generally a straighter shot down, so you can kind of see, you can see a little bit further down in it, and then the left kind of angles off a little bit more. So a lot of times when they're doing bronchs, as they're down there, they have an idea kind of where they are based on the length of the depth of how far they are into the lungs, but they often have to kind of pull back out so they can kind of visualize and kind of get their landmarks. So the carina is a great landmark to kind of know where you're going once they get in there. And then the cool thing about this is that as the physician is looking, and that's generally who does all of our scopes. As the physician is viewing through his eyepiece, it's also being connected up onto the monitor, so you can watch it too. Alright, so there's different indications for bronchoscopies, kind of broken up really in kind of two different categories, and you can kind of see it here: diagnostic and therapeutic, and then miscellaneous. So diagnostic, generally there's something suspicious on an x-ray or a CT scan, and so they decide to go in for a closer look with a bronchoscopy. Diagnostic to see what type of pneumonia, hemoptysis, persistent atelectasis, maybe there's a mucus plug or there's excessive secretions, trying to figure out why there's an unexplained or persistent pleural effusion, unexplained or persistent paralysis of the diaphragm, the interstitial lung disease to help diagnose. Unexplained hoarseness can also be a reason, kind of more so in the upper airway. Therapeutic, again, atelectasis, so obviously persistent atelectasis to diagnose what's going on, and then hopefully it could be a therapeutic in the fact that you find the reason and you're able to remove mucus plugs and secretions. Removal of foreign bodies, figuring out what's going on with the bleeding source, and also the interventional bronchoscopy. That's kind of what Victor's going to talk about, the EBIS, because that's also though more for diagnostic too. So different advanced procedures. And then miscellaneous for intubations and research. So occasionally, I mean, we have the kaleidoscope, which is just basically a laryngoscope with like a little camera on it. So it's just in the upper airway to kind of assist in intubation, so you can visualize the vocal cords a little bit better on the little camera, and it's just a kind of a little bit better tool that they use now. But sometimes they will definitely intubate using the bronchoscope, so then they just kind of thread the ET tube over the scope itself. Alright, so kind of backing up again, the therapeutic then bronchoscopy. Alright, got to hear the dogs bark again. So like I said, bronchoscopies are generally performed for two reasons: therapeutic and diagnostic. Therapeutic, again, to remove those secretions, mucus plugs, foreign body, causing basically part of the lung to collapse, so either a lobar or segmental atelectasis. And then, like I mentioned already, the diagnostic, to be able to look at these different tissue samples, help us diagnose different disease processes. They can look at cytology, histologic or microbiologic studies. Generally, they're kind of further investigating and infiltrate a mass or atelectasis. They can also biopsy these masses under fluoro is probably the best way to do it, fluoroscopy guided, so they can kind of see at the exact same time when they are and where they are to get the biopsies. There's another one that's a little video link that's interesting to watch. It's called electromagnetic navigation bronchoscopy. So it's kind of a newer technique that promises accurate navigation to the periphery, pulmonary target lesions, using kind of technology that's similar to GPS, with a CT to help map out for the biopsy or for radiation. So if they need to, biopsy it to kind of see what's going on, or to actually treat it. So that's kind of an interesting video clip to watch. Again, our indications, including therapeutic and diagnostic, could be hemoptysis. So therapeutic in the fact that we're cleaning it out, and diagnostic, trying to figure out where it comes from. Massive hemoptysis, remember, is generally more than 400 to 600 mils in a 24-hour period. A rigid scope is actually sometimes used with that large bore rigid scope to remove the blood. Then once you are free of the active bleeding, then a flexible scope should be looked to actually try to figure out where the source is and make sure it's not a cancer, rule out cancer. Pneumonia, again, you're looking to define the microorganism that's causing the pneumonia. A bronchoalveolar lavage, or BAL, is sometimes performed where you actually, and I'll talk about that on a slide coming up, actually I believe it's the next slide, where they actually instill about 100 cc's of normal saline, and then they pull it back up basically, so it's just kind of like a wash. They kind of go in there and lavage it. They're looking for different cells. So they usually do it in increments of like 4 to 5 syringes filled with about 20 to 30 mils of saline. You get a little bit of air behind them so you can get that push, so you can get it further down. So generally use about 100 mils. So you can have small bottles of saline that you'll put in your bowls, and you'll make sure that you have everything labeled as to what you are using, your medications, and even if it's saline, whatever you're using, lidocaine, epinephrine, you want to make sure you have everything labeled. Again, this is done mainly for diagnostic purposes, using the smears and cultures. I also look at cell count and differential with interstitial diseases. They can also look at to see if the cause is pulmonary alveolar proteinosis. I think that would be actually, a couple of you I think don't have your disease processes picked out. That might be a good one to do. And possibly with asthma, they may do a BAL for therapeutic reasons. So that pulmonary alveolar proteinosis is basically an accumulation of surfactant. It's very rare, but it's kind of cool. I did look it up, and there's, you know, pathophysiology on it. There's different x-rays, examples, so it might be something that if someone needs a topic, that might be one to pick. Interstitial lung diseases, keeping in mind there's like, what did I read, like 200 different types of interstitial lung diseases. So it's kind of a broad term. So with there being like 200 of them, it can be difficult sometimes to identify them. So on the next slide, I believe, on the next slide, I'll kind of talk a little bit, show you some different examples of them that come from the textbook. So again, interstitial lung diseases, there's infiltrates in these small bronchioles and the supporting tissues. They're hard to diagnose. You actually need tissue biopsy to confirm exactly what it is. A bronchoscope can help you with that, and some of the newer procedures like the EBIS and that can be a great alternative to open lung biopsy, because they used to have to actually open up the chest wall and get tissue out that way, and now the bronchoscopies are obviously less invasive, and they can actually be managed as an outpatient procedure. The BAL, that bronchoalveolar lavage, can also check for malignant cells. So here's an example of some of the different types of interstitial lung diseases. I know that some of these, I believe people have picked out. Again, if you haven't picked out your disease, this might be an example of some of them to pick out. There's that pulmonary alveolar proteinosis, and it's just kind of telling you the different techniques that you might use for being able to diagnose. So whether you're doing a TBB, which is a transbronchial biopsy, or if it's a BAL, which is your bronchoalveolar lavage, those seem to be the most common ones here that are mentioned. These two, and then we have So polymorphic nuclear cells or neutrophils are some of the findings that you're going to find depending on what your disease process is. So take this in consideration when you're doing your project, because you want to definitely include this diagnosing technique to help you confirm your diagnosis. All right, foreign bodies are a big one that they use to for bronchoscopy. I think Victor definitely said he's gotten a grape out of somebody's lung one time. I know some of us, well, we used to anyway, on the evening shift, we would go and help with endoscopies, and a lot of times it's again a similar procedure, just going through the esophagus and trying to figure out, because we basically help manage the airway. They don't intubate the patients for it, but they use a huge scope with a big oral airway piece and a bite block so they don't bite the scope, but just kind of making sure that they're breathing still, and just kind of an extra set of hands. We generally do that in the ER on after hours. So obviously you want to make sure, your biggest concern is to make sure you have a patent airway. So they will sometimes use a rigid scope to remove some of the larger objects, a smaller scope for the or flexible scope rather for smaller objects. Keeping in mind there's definitely complications, and this is complications really with any type of bronchoscopy. Suctioning can definitely cause hypoxemia and atelectasis, also damage to the airway depending what type of tool that they're using to grasp the object. There's like a little basket that opens up, kind of like almost like a claw, and that can grab onto things. The little biopsy, little alligator things are usually more for like tissue, but sometimes they might be able to pull something out depending what it is. Yeah, so you'll be able to watch that in those videos where they're trying to get out the different, the whistle and I think it's like a rose thorn. Pretty nasty. That thorn's kind of nasty because it's been in there a while. What else was I going to say? Oh, so I definitely have seen them even just for therapeutic bronchs. They just have to be, so part of our job is to make sure the ET tube is staying in the right place, that they're not dislodging it. So you want to be mindful of the depth of the tube before they start scoping, because they're going to move it around a little bit. And you're watching the heart rate, or watching the sat, blood pressure, making sure that you're getting, appropriate tidal volume return back. Obviously their peak airway pressures are going to be up because you've got this tube in the endotracheal tube, the scope rather than the endotracheal tube. So, they should be down there for, I don't know, a few seconds or so, like, sometimes it seems like forever, but 15-20 seconds, and then they really should try to pull back out again, because they will drop their sats. Sometimes they get really focused on trying to get done what they're trying to get done, whether it's the secretions or clearing an airway or whatever it is, but you have to kind of remind them that they're dropping their sats, or especially if they're having any arrhythmias or change in their heart rate and that, because it will take a while for them to recover from those procedures. So there's different characteristics and capabilities of the flexible bronchoscopes. They vary in sizes and applications. They have ultra thin ones that can examine and biopsy infant airways. The large diameter scopes. We have the bigger scopes when we have to remove foreign bodies to help facilitate the suctioning and doing the washings. It just depends what the goal is, why you're scoping them, depending on which scope they use. So we do have, like I said, a bigger one, and they'll generally say that's what they want, or if they're not sure, just bring it up to say, do you want a bigger scope or just a regular size scope? Again, the digital scopes allow us to look on the video monitors, and they can actually take photos of that and little video snippets. And then lasers can be directed from the scope tip to actually obliterate large airway tumors. the different devices, like I kind of mentioned, that can be passed down through a scope. So again, it's a port on the side of the scope. You can have like these little biting and grasping forceps. They can grab little sample bites of tissue. There's different types of brushes. There's an unshielded brush that's used for tumor masses, and then there's a double shielded brush that's used for bacteria samples, and they double shield it so it prevents any kind of contamination before it actually gets down to the site, so you can keep it protected, like a protected brush. You get down there where you need to sample, and then you cover it back up with the double shield and then withdraw it. Those little basket grabbers, again, different types of grasping forceps, different sizes. There's retrieval snares. They're kind of like a little hook type of thing, like a wire kind of hook. They can remove different objects that might have been aspirated. And like I mentioned on the previous page, lasers can remove tumors. You have to be really careful with them, because if you have an FiO2, if the patient's on an FiO2 greater than 30%, it can actually cause a fire. So just be mindful of that. So here is a retrieval snare. The one on the left kind of also reminds me of the little basket kind of thing. It could be maybe the same type of deal, because it's not obviously like that when they put it in. It's more on the little upper diagram, and then you're actually the one that kind of helps manipulate it. So it's like a I guess a syringe type of thing. It has like little things on it with your fingers, and you kind of push, and then they can see, the physician, and of course you can see too, but you're really paying attention to what they're doing. And they'll tell you like open, close, so you kind of push the basket out and then open it up and then try to grab it and then pull it back out. So they'll kind of direct you on what you should be doing. This electrical surgical snare, that's kind of like that little loop thing, and it actually can burn off tissue too. So it can give an electric current that it can actually get rid of growths. Okay, so the EBUS, this is endobronchial ultrasound bronchoscopy. And like I said, Victor will talk a little bit more about it. It's considered minimally invasive, highly effective procedure that can help diagnose lung cancer, infections, and other diseases that involve large mediastinal lymph nodes. They then are able to use this transbronchial needle aspiration. So it's like a needle that kind of again goes through the scope, and then you are able to kind of aspirate the fluid or the tissue or whatever it is you're biopsying. It helps determine the staging of lung cancer, which is important, where before they had to do that with an open lung biopsy. It's useful in diagnosing inflammatory lung diseases such as sarcoidosis and lymphomas. The nice thing about it is that they usually have a pathologist right there at the bedside, so they're able to look at the tissue or the sample right away and have an idea of what's going on. They can kind of tell pretty much right away if it's cancerous. It's again less invasive. It provides real-time imaging of the surface of the airways, blood vessels, lymph nodes, and the lungs. It's performed under moderate sedation or general anesthesia, so like that conscious sedation thing where you're pretty much out of it, but you can still sort of follow commands. You're generally given Versed and fentanyl, so you don't remember any of it. And most patients tolerate it really well and are able to go home the same day. Here's a little video segment that I included on it. Alright, so now we're going to talk about some of the complications. Of course, like any type of procedure, there can be complications. One of the most common ones is adverse effects of your medications. So for an example, lidocaine. Lidocaine, if you give too much lidocaine, you can actually cause a seizure. So you want to make sure that you stay under 300 milligrams. Obviously, hypoxemia can be a complication of a bronchoscopy because you're sucking the air out of them. When you're applying the suction, because you're usually, a lot of times it's for secretions or you see something there, so applying the suction is definitely something that happens quite a bit. Hypercarbia, because you're not ventilating them as effectively. You can have bronchospasm, hypotension, laryngospasm, bradycardia, or other vagal response. Mechanical complications include epistaxis, which is a bloody nose, a pneumothorax, hemoptysis, so you can cause hemoptysis, obviously increased airway resistance because you have a foreign body in the airway, death, cross-contamination with your specimens or your scopes, nausea, vomiting, fever, chills after the fact if you're possibly induced some type of infection, cardiac arrhythmias, dysrhythmias. So what else did I want to say? Yeah, possibly a low-grade fever. Like I said, infection, 5% of the patients develop transient low-grade fever. Kind of comes and goes, is what that means. And side effects of the anesthetic. Alright, so when you are doing your bronchoscopy, whether it's an outpatient or inpatient, really, you need to have your equipment ready. It's generally considered safe and inexpensive. The room should be equipped with, obviously, adequate suction, oxygen. You want to make sure you're able to monitor the patient. You want to monitor their heart rhythm, you're monitoring their sats, you're monitoring their blood pressure. You want to have different oxygen delivery devices available. Definitely have your crash cart, bag mask valve, intubation stuff ready, defibrillator, and the different types of drugs. The Narcan and flumazenol. Flumazenol are your reversals for your narcotics or your opioids, and making sure you have a complete patient history and examination. Make sure that they're aware of their procedure. Making sure they're not on any blood thinners. Making sure that obviously they're, I think I said, allergic to any medications. Why you're doing the bronchoscopy. If they're on home oxygen already, just being aware of all that. They have a history of arrhythmias. So here are some of the contraindications. So you're not going to want to do a bronchoscopy if your patient has had a recent MI, if they're not cooperative, if they have unstable severe asthma or severe hypoxemia or severe hypercapnia, if they have a bleeding disorder. So this is all part of obtaining your history, making sure they don't have any of these things going on. Potentially lethal cardiac arrhythmia, abscess, because you could potentially spread that or burst it, or spread the infection. Renal failure, some of the medications don't clear right. If they're immunosuppressed because you're doing an invasive procedure, you don't want to make them more sick. Obstruction of the superior vena cava, because it could affect the return blood flow. So wanting to make sure, and a lot of these instructions are obviously given to the patient, and this is like a kind of pre-op stuff that nursing generally goes over, or anesthesia, or the physician, but you just want to double check that the patient has been fasting for 6 hours, because you don't want to have any risk of aspiration. Obviously they need to sign the consent. The physician goes over all that. That includes the risk and complications of the procedure. You need to have the patient sitting up. We generally pre-medicate them with a 4% xylocaine or lidocaine. It's the same thing. So via a nebulizer, small volume nebulizer. An IV needs to be started, so there's generally always a nurse there, because we can't administer those sedation medications. They have to, or the physician does. So want to make sure that an IV is started. They sometimes will use xylocaine to numb the nostrils. as they go through the nose when they do the scopes. Occasionally they'll go through the mouth, but it's easier and a little more slick if they can go through the nose, and you don't have to worry about them biting the scope. And now if they're intubated, they'll go through the ET tube. So, but they're generally not an outpatient if they're intubated. You want to make sure that you've put them on oxygen, usually about 4 to 6 liters, making sure that you have the suction line attached to the specimen trap and the scope. You may want to have a couple different specimen traps. I mean, when you start working, or you're in the hospital, and hopefully you'll be able to see one of these. They'll go through all this with you. I mean, you have to be checked off for these types of things to be able to do them. But you'll have so the suction comes off the canister and then to the specimen trap, and then generally you kind of tape it either to the side of the cart, the bronchoscope cart, or the scope kind of itself. You just want to make sure that that specimen trap doesn't get tipped, because if it gets tipped or to an angle, then your suction is going to suction right back out of the trap. So there's your specimen loss. So you want to make sure that that doesn't happen. Then obviously once everything's set up and ready to go and you have everything labeled, they'll go ahead and they'll administer the medications to make them sleepy. Fentanyl and Versed are common choices. So you want this conscious sedation. So they kind of talk to the patient and kind of assess their level of consciousness. Hopefully they're relaxed. They're going to cough some, but the lidocaine helps, because then you instill a little bit of lidocaine before the cords, and then usually it's 2% above the cords and 1% below the cords. And the physician tells you, when to instill that, when to put that in through the scope. Let's see. Obviously you want to make sure you have all your PPE, so gown is not a bad idea for sure, gloves, mask, and goggles. You want to make sure that you're going to have, again, everything labeled. So 4% is generally given nebulizer, 2% above the cords, and 1% below the cords. Okay, so just wrapping it up here. So again, like I mentioned, the different doses of lidocaine, they generally have all that generally stocked in your drawer. Kind of depends on your facility. Sometimes though they don't, it has to be locked up obviously, and it's just the lidocaine and the benzocaine, but otherwise you might have to pull it out of your Pyxis, your med supply. Making sure you're keeping track of how much and the correct dosage, so you can chart that. Obviously different types of brushes or needle biopsies if you're doing that for needle aspiration, and then the biopsy forceps. So after the procedure, you want to make sure that you are closely monitoring the patient with their vital signs and their SAT about every 5 to 15 minutes, making sure they're starting to wake up. Be aware of any discomfort they might be having, or bleeding, or respiratory distress. Make sure you notify the physician of any changes that are going on. The patient can be discharged or sent home or go back up to the floor when they're alert and oriented and have an intact gag reflex, that the vital signs are stable and there is no bleeding and their throat is feeling back to normal. Generally the nurses go through the discharge instructions with them, but it's important that we're aware of what needs to be back normal for them before they can go home. And then other roles that we have are making sure that the specimens are labeled properly. It can sometimes include these different tissue biopsies, brushings, the needle aspirations, washings like from the BAL. You want to make sure you have the patient's name, all their numbers, the history numbers, the physician's numbers. Make sure you have the order and that it's been signed, that the lab has the order so they can run the specimens, the date and the site of origin, so where the specimens were obtained from. Make sure everything is attached. Obviously, you want to make sure that you've completed all your charting, which includes noting the procedure, the indications for it, the medications that were used, specimens that were collected, and any tests that were requested for them to go on to further diagnose and treat. For sure, making any note of complications or post-procedure impression, like patient tolerated the procedure well. Here again is another kind of list of the medications, a few added things. So like I mentioned before, you want to make sure that you're keeping an eye on how much lidocaine they get, and that includes benzocaine. Benzocaine is also the same family as lidocaine, because you want to make sure that you avoid methemoglobinemia. So you really want to make sure that the dose of lidocaine is limited to about 5 to 7 milligrams per kilogram. And I know I mentioned 300 milligrams before. Egan says 400 to 500 milligrams in a 150-pound adult, especially those in elderly patients have a harder time clearing that, and those with liver or cardiac disease. So just keep in mind how much lidocaine is being given. Also, things that you'll have available, atropine can help dry up the secretions. Epinephrine can sometimes be given for bleeding management. Obviously, bleeding is an issue. Another thing that they may try before they do the epi is just some iced saline. So have 10 or 20 cc's of iced saline. So you have them already drawn up in your syringes and they're on ice. So that sometimes just helps with the bleeding. And then your medications for sedation, including your fentanyl, Versed, and Ativan. And again, those are administered by the MD or the nurse. And all the different complications. I know I mentioned these before, but I want to include them again. I think they were in a chart or a graph table, whatever. So just keep in mind of those. So that is it for today, and look forward to Victor's add-on. I'll have added what I want to say, PowerPoint lecture. Sorry, I'm trying to watch the dogs and they're being terrible. But we'll talk later. Bye.